Hello people and welcome to Med Novice, where we make tough medical stuff make sense. And the today's topic for discussion is cell death. So basically when the stress on a cell overpowers its ability to adapt, it further progresses to reversible cell injury, then to irreversible cell injury. Then in that case the fate of cell is ultimately death, right? So the morphologic hallmark for cell death is loss of nucleus, and this occurs in 3 steps. The first one being pycnosis, which is followed by karyorrhexis, which is further followed by karyolysis. So what happens in pycnosis is that the nucleus shrinks down like an ink dot, and then in karyorrhexis the shrunken nucleus breaks down into big pieces or big fragments, and then in karyolysis these big fragments basically break down to the building blocks, right? So these are the 3 steps of loss of nucleus, which is the morphologic hallmark of cell death. Now coming to the mechanisms of cell death, there are 2 mechanisms. First one being necrosis, and the second one being apoptosis, right? So in layman terms, to understand this, you can say that necrosis is murder, while apoptosis is suicide. Now coming to the first topic of discussion, that is necrosis. Okay. So what happens in necrosis is that there is death of large group of cells, right? Important point. There is death of large group of cells. Okay. And it is followed by acute inflammation. This is one important point and one important differentiator between necrosis and this thing, apoptosis, right? Necrosis is followed by acute inflammation. And the third and quite important point again is that necrosis is always pathological. Always pathological. Okay. Now coming to the types of necrosis, the first one what we will be discussing is coagulative necrosis. Right. So as the term is indicative, coagulative necrosis, there would be coagulation of something. What is that thing? That is proteins. So there is coagulation of proteins. Okay. There is coagulation of proteins, and due to which the cell shape and organ structure are preserved. But as it is cell death, what you will see is that the nucleus is lost, right? The nucleus disappears. And why the cell shape and organ structure are preserved? It is due to the coagulation of proteins. And one important thing, the example of coagulative necrosis, it is the characteristic of ischemic infarction, right? It is the characteristic of ischemic infarction. But except for ischemic infarction in brain, which we will see why. Okay. So it is characteristic of ischemic infarction except brain. Except brain. Now one more important point what we need to see here is that the shape of infarcted tissue, right? The area of infarcted tissue is usually wedge shaped, and it will be pale on gross appearance. So why it is wedge shaped? Why it is wedge shaped? Let's say you have this organ, right? You have some big organ here, and you are considering this area of infarct. So what happens is, if you will see the blood supply here, right? Just a second. If you see the blood supply here, let's say this is one main blood vessel coming. It will branch, right? It will further branch. It will further branch. But one thing what you will see is, let's say this is the point of occlusion, right? Let's say this is the point of occlusion of the blood vessel. What you will see is that all the branching is dichotomous. Okay, all the branching is dichotomous. Now if this is the point of occlusion, there will be no blood flow further downwards, right? There will be no blood flow further downwards, due to which this area lying under this perimeter, under this triangular perimeter, will be infarcted, right? And this is the reason why you see that the infarct is usually wedge shaped. Why it is so? It is due to the dichotomous branching of blood vessels. So these were the important points to discuss in coagulative necrosis. Next we will move towards liquefactive necrosis. Next we will move towards liquefactive necrosis. Now what happens in liquefactive necrosis, as the term is indicative, there would be liquefaction of the tissue, right? And why liquefaction of tissue is taking place? It is due to the enzymatic lysis of cells. Okay, enzymatic lysis of cells and proteins. There the proteins were not undergoing lysis, instead they were coagulated, due to which the entire structure was preserved in case of coagulative necrosis, right? But here there is enzymatic lysis, due to which liquefaction will occur. Now coming to the examples, we said coagulative necrosis is characteristic of ischemic infarction except for brain. So what happens in brain is that the microglial cells release enzymes which will basically lead to the liquefaction of the infarct, right? So in brain infarction, you will see liquefactive necrosis, and it is mediated by microglial cells. Okay, so this is the first example. Coming to the second example, in case of abscess formation, you will see liquefactive necrosis, and it is due to the enzymes released by neutrophils, right? It is due to the enzyme released by neutrophils. And coming to the third example, you can see it in pancreatitis, wherein what happens is, this is one interesting phenomena, where what you see is that pancreatic enzymes act on the pancreatic parenchyma itself, right, leading to autodigestion of the pancreas. So this happens during autodigestion of pancreas. So in pancreatitis, when you see autodigestion of pancreas occurring, that is an example of liquefactive necrosis. The tissue will undergo liquefaction, right? Now coming to our third topic of discussion, the third type of necrosis, that is gangrenous necrosis. Gangrenous necrosis. Okay. So what happens in gangrenous necrosis is that coagulative necrosis is there, and it mainly resembles mummified tissue. Talking first about the dry gangrene. It is basically of two types. One is the dry gangrene and the other one is the wet gangrene, right? So in dry gangrene, what you will see is a coagulative necrosis that will be resembling mummified tissue, right? And again, this is characteristic of ischemia of lower limb. So coming to dry gangrene, it is a characteristic of ischemia of the lower limb, right, and the GI tract. Okay, so what happens is, basically, let's say you have atherosclerosis and the popliteal artery is blocked. Okay, the popliteal artery is blocked partially, so that will lead to decreased blood flow in the lower limbs, which is common in diabetics, right? Which is common in diabetics. So this is one example of dry gangrene wherein you had a coagulative necrosis, resembling mummified tissue. Okay, so this was dry gangrene. Now coming to wet gangrene. Now if this dry gangrene is having a superimposed infection, right, then liquefactive necrosis also ensues, due to which the gangrene will become wet, basically due to the liquefaction of the tissue. Okay, so if any bacterial infection superimposes this dry gangrene, it will lead to wet gangrene, right? Superimposition of infection on dry gangrene, that will lead to wet gangrene. Now coming to the fourth type of necrosis. The fourth type of necrosis is caseous necrosis. Okay. So what do we see in caseous necrosis? You will see a soft, friable necrotic tissue, right, with cottage cheese-like appearance. There will be cottage cheese-like appearance. Okay. And it is usually seen when you have granulomatous inflammation due to tuberculosis or fungal infection. So that is the example for caseous necrosis, which is granulomatous inflammation due to TB or fungal infection. Okay, and you can say that caseous necrosis is a combination of coagulative and liquefactive necrosis. So these were the important points in caseous necrosis. Now moving to the fifth type, that is fat necrosis. Okay, so what happens in fat necrosis is that the necrotic adipose tissue has a chalky white appearance, right? So first of all, which tissue undergoes necrosis? That is adipose tissue. And what do you see? You see a chalky white appearance. And why is that chalky white appearance? It is due to deposition of calcium. So you have necrotic adipose tissue, and it is with chalky white appearance, which is due to deposition of calcium. Okay. Coming to the examples, right? So there can be fat necrosis in peripancreatic fat. There can be fat necrosis in peripancreatic fat, right? And this is a pancreatitis mediated damage, right? You will see usually it occurs along with pancreatitis, wherein the peripancreatic fat undergoes necrosis and it is mediated by all that autodigestion going on in case of pancreatitis, right? Another example is if there is trauma to a adipose tissue, for example in case of trauma to breast, right? So trauma to breast, there also you will see fat necrosis. Now coming to this calcium deposition, basically what happens is that fatty acids, as there will be fat necrosis, fatty acids will be released, they bind with calcium, and this process is called saponification. This process is called saponification, due to which calcium deposits basically in that necrotic tissue. Now coming to this thing, see, in general deposition of calcium, you can say it is calcification, right? And calcification can be of two types. Deposition of calcium is calcification. It can be of two types. The first one being dystrophic calcification, and the second one being metastatic calcification. Okay. So these are the two types of calcification. Now what happens that calcium naturally never does deposit in our body, right? But when can it deposit? So the first case is if there is necrosis, right? There is a dying tissue, and there what happens that fatty acids are released and they bind with calcium. Basically the saponification process occurs, right? So that is one case where you can see calcium deposition on dying tissue, and that is basically dystrophic calcification. So if the calcification occurs on dying tissue, it is dystrophic calcification. And one more important thing is that the serum calcium and phosphate are normal here, right? The serum calcium and phosphate are normal here. The calcium deposition is not due to increased serum calcium or phosphate. It is due to the dying tissue in which the fatty acids are being released and saponification process is occurring, right? But in case of metastatic calcification, what happens is that your serum calcium and phosphate are high. So calcium and phosphate go high in the serum, due to which what body thinks is that the excess calcium can be deposited in some of the tissues, right? So the excess calcium is forced into tissues, which will lead to precipitation of calcium in tissues, and this is metastatic calcification. So this is a key differentiator between these two types of calcification. You can check for serum calcium levels, serum phosphate levels, right? Now coming to the final type of necrosis under discussion, that is fibrinoid necrosis. Okay. So in case of fibrinoid necrosis, the necrotic damage happens to the blood vessel wall. Okay. Necrotic damage is to the blood vessel wall. Okay. And due to the damage to blood vessel wall, what will happen is the proteins will be leaked from vessel wall into the flowing blood, right? So there will be leaking of proteins into the vessel wall, and that will lead to bright pink staining. So as there is necrotic damage to blood vessel wall, there will be leaking of proteins into the vessel wall, and due to which what you will see as a result, there will be bright pink staining of the blood vessel wall. Okay. So this is what you see in case of fibrinoid necrosis under the microscope. Now it is a characteristic. It is a characteristic of malignant hypertension. Right. It is a characteristic of malignant hypertension or vasculitis. These are the two cases where you can see that the blood vessel wall is facing necrotic damage, right? And there you can find out that fibrinoid necrosis is taking place. Now, what exactly do we mean by malignant hypertension? So basically you can classify hypertension into two types. One being benign hypertension and the other one being malignant hypertension. Okay, so benign hypertension is basically a low-grade hypertension. Low-grade hypertension, and it leads to long-term progressive chronic damage to organs, right? It leads to long-term progressive chronic damage to organs. And coming to the malignant hypertension, here suddenly the BP goes very high, right? And this will result in, suddenly the BP goes very high, this will result in headache. It can also result in renal failure, right? Sorry. It can result in renal failure, headache, and it can result in edema. And due to this such a high increase in the blood pressure, what can happen? The blood vessel wall can damage. Hence, fibrinoid necrosis is a characteristic of malignant hypertension, right? With this, we complete our first mechanism of cell death, that is necrosis. Now we will move to the second mechanism, that is apoptosis. So some basic things about apoptosis are that first of all, it is an energy dependent process, right? It is energy dependent process and it is genetically programmed. It is genetically programmed. Hence it is also called as programmed cell death, right? It is genetically programmed and it involves single cells or small group of cells. So it involves single cell or small group of cell. Whereas in necrosis what we saw was that large group of cells were involved, right? And one more thing, that necrosis is followed by acute inflammation, but apoptosis is not followed by acute inflammation. Okay. Now coming to the examples where you can see apoptosis, the examples are, first one, endometrial shedding. Right, it can happen in case of endometrial shedding. It can happen in case of removal of cells during embryogenesis. It can happen during removal of cells during the embryogenesis process, right? And the third example to it is CD8 plus T cell mediated killing. killing of virally infected cells. Virally infected cells. So what will happen is basically, talking about this third example, virus will infect the cell, right? What it will do is it will use the cell's machinery. It will use the cell's machinery to synthesize its own proteins, right? And basically viral proteins will be formed endogenously, right? They will be formed endogenously, and hence they will be expressed on MHC1, right? As they are being formed endogenously, these viral proteins are being formed endogenously, they will be expressed on MHC1. MHC1 is something present on all nucleated cells and platelets, right? And it has an important role in immunology. We will be discussing further in immunology lectures. So basically these viral proteins, as they are generated endogenously, would be expressed on MHC1. And as they are expressed on MHC1, we know that the CD8 positive T cells, they will identify these expressed proteins on MHC1, and that will induce the apoptosis of infected cell. Right, that will be inducing the apoptosis of your infected cells, virally infected cells. Now coming to the term apoptosis, basically this term has arisen from a Greek word which literally means falling of leaves. So why has it been named so, right? Based on a Greek word which means falling of leaves. So what happens is that when the dying cell shrinks, right, as the cell is dying, it will shrink basically. And as it will shrink, the cytoplasm of the cell will become more concentrated, right? So it will become eosinophilic. After the cell shrinks, what you will see is that the nucleus shrinks, right? Pycnosis will occur. And as the nucleus shrinks and then further condenses and fragments, what will happen is that apoptotic bodies will be formed, right? Small fragmented bodies will be formed, which are referred to as apoptotic bodies. And these apoptotic bodies, they will basically fall off from the cell, just like leaves fall from the tree. And they are then further removed by macrophages. They are then further removed by macrophages, right? So that's why it is named on a term which literally means falling of leaves, because the apoptotic bodies, they feel like they're falling from the cell in the same way as leaves fall from the trees, right? So another thing to see here is that after these apoptotic bodies are removed by macrophages, there is no acute inflammation, right? No inflammatory response is generated. This is one important differentiator of apoptosis from necrosis. Now, important point is that there is a molecule that mediates apoptosis, and its name is caspase, right? So caspases are mediators of apoptosis. Hence, whenever you want to induce apoptosis, you need to basically activate these caspases, right? You want to activate these caspases, and they will further lead to apoptosis. Now, what do these caspases do? Now see, you have to kill the cell, right? The cell has to die. So you will have to break down the framework. Now as the cytoskeleton has to be broken down, and the cytoskeleton, as we all know, is made up of proteins. So what is the enzyme that will be needed here? Proteases, right? So caspases activate proteases. And what is the second enzyme that is being activated? You need to degrade the entire genetic material out there, right? So the second thing what will be activated is endonuclease. So how do caspases function? They basically activate your proteases and endonucleases, right? The proteases will lead to the breakdown of cytoskeleton, while the endonucleases will lead to the breakdown of DNA. Now, as we saw that if you want to induce apoptosis, you need to activate caspases. Now, there are three ways to activate the caspase, right? So we'll be discussing the mechanisms of apoptosis basically. There are three ways to activate the caspase. The first one being intrinsic mitochondrial pathway. Right. As the term is suggestive, here the activation of caspase is due to something which is intrinsic, which is already present inside the cell, right? So what happens here is that if there is a cellular injury, as we saw in cellular injury, there will be membrane damage, right? So there can be a damage induced to the mitochondrial membrane, or if there is DNA damage, right? Or if there is decreased hormonal stimulation, as in the case of endometrial shedding, right? So in these conditions, what happens is that a protein is there, BCL2, it gets inactivated, right? So the BCL2 gets inactivated. Now what exactly BCL2 does is that its function is mainly to stabilize the mitochondrial membrane, right? And if the mitochondrial membrane remains stable, then cytochrome C remains within the mitochondria, right? It can't escape the mitochondria. But as in these situations, the BCL2 has been inactivated, the mitochondrial membrane won't be stable, right? Due to which what will happen? Cytochrome C will leak into the cytoplasm, right? And what does cytochrome C do? It is an activator of caspase. So what we see in your intrinsic mitochondrial pathway, in conditions of cellular injury or DNA damage or decreased hormonal stimulation, as seen in the case of endometrial shedding, the BCL2 is inactivated, and as the BCL2 inactivates, the stability of mitochondrial membrane reduces, due to which the cytochrome C leaks into cytoplasm, and cytochrome C we know is activator of caspase. So now caspase has been activated, and further it will mediate the apoptotic process, right? Coming to the second pathway, the second pathway is extrinsic receptor ligand pathway. Extrinsic pathway, right? Extrinsic receptor ligand pathway. What happens here is that something from the outside world comes and binds the receptor on cell, and that activates apoptosis, right? Now, due to the secondary messengers and all those messaging systems going on within the cell, right, this binding of the ligand to the receptor will lead to activation of caspase, which will further lead to the apoptotic process taking place, right? So one classic example is fast ligand binding to fast death receptors, right? To your knowledge, fast death receptors are CD95. Okay, so let's discuss this in a bit detail. What happens is basically you have T cells, right? These T cells are born in bone marrow, and for maturation they go to thymus, right? Now when they reach thymus, what happens is that there is testing of these T cells, right? And there are two layers of testing. Okay. So what is the first layer of testing? The first layer of testing is positive selection. So the concept here basically is, and the second layer is negative selection. Okay. So the concept here basically is that the T cells which have reached and matured in thymus can be of three types, right? We classify it functionally that it can bind to self-antigen, either it can bind to MHC, right? Or it cannot bind to any of these. Let's say that to be nota, okay? None of the above. So either it will bind to none of the above, or it will bind to self-antigen and MHC. So binding too strongly to self-antigen, that will lead to immune reactions against our own cells, right? So that is not favorable. And not binding to antigens, then the T cells function won't be served. So that is also not favorable, right? So first, in positive selection, what we do is we remove this nota. Okay. Those T cells which don't bind to the self antigen and MHC, right? They are removed. And if they bind to self antigen and MHC, they survive, right? Now you have got T cells who bind to self antigen and MHC. You want to select out those that bind too strongly to the self antigen, right? Those T cells which bind too avidly to the self antigen need to be removed, and that is done in negative selection, right? So the question what you are basically asking in negative selection is that does the T cell have ability to bind to the self antigen too avidly? If yes, then the T cell is destroyed, and that destruction occurs by the extrinsic pathway. And particular example in this case, the fast ligand, fast receptor, fast death receptor pathway. Okay, wherein a ligand comes from the outer world, right? Ligand comes from out of the cell. The fast ligand comes, it binds to the fast death receptor, which will lead to activation of caspases, which will further mediate the apoptotic process. Another example where you can see this is the tumor necrosis factor binding to TNF receptor on target cell, right? So in case of tumor necrosis factor also, you can see the extrinsic pathway is taking place. Now coming to the third and final mechanism to activate the caspase, that is the cytotoxic CD8 plus T cell pathway. Okay, cytotoxic CD8 plus T cell pathway. Now what happens here is, as we saw in case of viral infected cells, you have an antigen on MHC1, right? You have an antigen on MHC1 which is being identified by the CD8 plus T cell. So CD8 plus T cell identifies it, and what does it do is it releases perforins. Now these perforins, as the name is indicative clearly, what do? They create pores in membrane of target cell, right? They create pores in membrane of target cells. Now these pores are created, the membrane has been damaged. Now what will happen? They will release something called granzymes, and these granzymes will enter through the pores which have been created, right? The CD8 plus T cell, first they released perforin which created a pore in membrane of the target cell, and then they released granzymes. The CD8 plus T cell released granzymes which then enter through these pores, and what they do? They will further lead to activation of caspases. These granzymes will activate the caspases, and now as the caspases have been activated, apoptosis will take place. So this was the third mechanism to activate caspases and induce apoptosis. With this we conclude our discussion on cell death. If this video helped you, don't forget to like, share and subscribe. This is Med Novice, learning medicine the simpler way. Thank you.